Okay, so welcome all the faculty members and our mentors and all the students who are wanting to learn more about myelofibrosis today. And this is the icon Amrita E-Gurukul series, which is basically a continuation from our physical gurukuls, which have been very successful and have been very well appreciated by our students. And so this was conceived as a continuation of the same endeavor, in an online format. And the icon team and Dr. Karan Sood and our course directors, Dr. MB Agrawal, Dr. Purvish Parekh, their immense support, and our team members, everybody has kind of put together this program and is going to continue for longer, and probably it's going to be weekly for a few weeks to cover some of the important topics for student exams. And then we hope to continue it monthly, based on the need and the kind of updates there are in the various disease subgroups. So can we have the next slide? So first and foremost, I would like to introduce everybody. All of us do know him as our mentor. And for me it's also a personal journey with him, because I met him probably in 2015, early 2015. And there was one question about liquid biopsies in one of the meetings, icon meetings. And I said something about liquid biopsy and diagnostics. And then he kind of liked that comment of mine, and thereafter he sent me a message while I was boarding the plane. And it really excited me that somebody as senior and of such a stature as him is messaging me that some of my comments were appreciated by him. And it really boosted me, inspired me. And and since then it has been a long journey with him, learning from him every day, and the way we should conduct our academics and our life and our handling, managing our patients. A lot of learning from him. So, and his credentials are there on the screen for all to see. But it is much beyond that what I have personally learned from him, and many of us students and his students. And he has been a great mentor for all of us. So now he is also the director of course director of this very program. And I thank him for taking this up, an icon for taking this up in a beautiful manner. So another mentor, on the next slide. Uh, so thank you, sir. And another mentor, which around the same time, Dr. MB Agrawal, he met me. He's not there in the meeting today, but I would like to say, a few lines about him. I used BTKI to treat a very difficult lymphoma in 2016-17, and he went into CR. And BTKIs had just come in at that particular time, and it was more of an a compassionate use for this particular patient. We got the drug also for free for this, and thereafter I shared this story with Dr. MB Agrawal, and he was so appreciative. And I presented that case in one of the IBCC meetings, and that's how my journey with him started. And he is a professor head in Bombay Hospital, and we all know him as an academician and a great teacher for all of us. And he is also supporting this initiative as a course director, and MHG also is, thanks to him. Next slide. So we have a very dynamic young doctor. He has many facets, and he is there on online for all of us to see on Twitter. He's very popular there. And he shares his pearls and anecdotes there on Twitter. And so happy to see him doing so well. And he's in Canada these days, learning there, and sharing his knowledge all the time, which is great. Dr. Nihar Desai, he is a hematologist, and how he took up hematology is also quite well known to all of us. And he's here with us to share more about myelofibrosis. And we have one of our good friends, and Nihar's also good friend, Nico. Can you move to the next slide? Dr. Nico Gagelmann from University Medical Center of Hamburg, Germany. He has beautiful papers on myelofibrosis. And I know when we thought that we will talk about myelofibrosis, I could not think of anybody else than Nico. to speak about this and share his wisdom with our students. He has beautiful papers on transplant and myelofibrosis, the nuanced management of myelofibrosis, how we work up the patient, how we prepare the patient, what is the risk stratification, what is the TRM, how to reduce it, how to use ruxolitinib properly, what to do about the spleen. All these pearls are going to come from him today in this meeting. So I think the next slide. Can we move? Yeah. So I think we can, start the program now. And, Karan, would you, I would invite the speaker. I think it's Nihar next to share, the
Sir,
basics of.
before the speaker talk, if we can just invite Dr. Puresh Parikh to give a few words.
Yes. Yes. So, sorry for, sir. Sir, please,
Thank you, Prashant.
please open the meeting with your, wisdom.
So, as Prashant mentioned, I am now senior, and therefore I am on the backside, behind the scene. So, I would like to continue to remain there. But it has been a wonderful interaction and planning for this meeting, especially all the hard work that Karan and Prashant have done. So, I'm really appreciative of all that. And Prashant, as we know, is now one of the masters of cellular therapies in India also. So that is going to be of immense benefit to the students. So I don't want to take more time. I think our international faculty have so much to share with us. So back to you, Prashant.
Thank you so much, sir. Really, great to have your, wisdom and your words, of support for this very initiative. And, I would invite Dr. Nihar Desai to take up this topic and, share his knowledge with us and all the students here.
Hello. Hi. Good evening, everyone. Thank you, Dr. Mehta, for the invite. Thank you, Karan, for getting all of this together. And thank you, Purvi sir, for, again, the invite and making sure this thing goes on smoothly. I believe I already sent my slides and I could see them, but I'm unable to do so now. Is there a way someone could share the slides?
So if you have your slides open in your laptop, you can just press on the share screen button in the center of your Zoom screen.
Yeah, and but let me just figure it out. Yeah, I didn't want to share the slide. Yeah, okay, here you go. Can you see it?
Yes.
Yes, sir.
And it's now on presenter mode, I believe.
Yes, sir.
Okay, wonderful. Thank you again for the invite. So I'll be talking all about myelofibrosis today. I'm not going to be talking about transplant, although I would have loved to, but I'll leave that to my good friend Nico to continue. He's running a bit late. He just texted me, but he should join for his session. So I am Nihar. I am currently working at the Hans Messner Allogenic Blood and Transplant Program at the Princess Margaret Cancer Center, the Temeti Faculty of Medicine at University of Toronto. So I have no relevant conflicts of interest with regards this talk, and I'm pretty excited to talk about myelofibrosis. It's something which is very close to my heart, and I work with one of the world leaders here, Dr. Vikas Gupta and Dr. Auro Viswapandya. So we've done a fair bit of research in myelofibrosis, and we transplant close to 250 patients in a year, of which close to 100 are myelofibrosis. So really, really appreciate this invite, and the topic is really close to my heart. So just a brief outline and the goals for today's session. I'll be explaining to the students and fellows. I was told that this would include a lot of medicine and medonc trainees as well. So it's not something medonc trainees may see that often. So I'll just give a brief outline of what myelofibrosis is. I will then share some images. They are not my images. I'm not a pathologist or a hematopathologist. I have zero skills there, but I did find some very good images from the ASH image bank. I'll be sharing some of those. I'll briefly touch upon the pathophysiology of the disease, acknowledging that there is so much that is still not known about this disease. Eventually, we'll obviously get into the clinical aspects of how the patient presents, how we end up diagnosing this disease, and I'll be sharing the diagnostic criteria. Eventually, we need to risk stratify these patients because myelofibrosis is a very large entity. It's very heterogeneous in presentation as well as in prognostically. And eventually we will delve a bit into the management of the disease. I'll just talk a bit about the drugs and the ones which are approved in 2024 and 2025. And do all patients need an allogeneic transplant? Answer is no, but a lot of patients do need it. And being a transplanter, I am biased towards transplanting more patients than not. But I'll leave that to my good friend Nico again. He's going to be talking about transplant, peri-transplant management of these patients, as well as some conditioning regimens and GVHD prophylaxis regimens. Post-transplant follow-up and all of that will be covered in his talk in the next half an hour. So I'm going to start with a case. Mr. X or Y or Z or whatever comes to your clinic. He's a 65-year-old man, presents with fatigue and low-grade fever. Again, a very, very common symptom, huge differential. As a physician, you order some labs, you get the hemoglobin back. It's 8.4 gram per deciliter or 84 gram per liter, whatever unit you like. The white cells are elevated at 34,000 with some blasts in the circulation, so nothing good can come out of it. The platelets are around 480,000, also slightly elevated, as is the LDH, which is almost 2 to 3 times the upper limit. I may not have the best clinical skills, but I still palpated a spleen 9 centimeter below the costal margin. Well, fair enough. I don't trust the clinical skills, so I put him in the donut of truth, and it confirms my findings. So we do see that this CT image here, sagittal section, shows that the spleen is quite enlarged. You can see that it's taking up a lot of volume in the abdomen. You also may appreciate a bit of hepatomegaly, but the spleen is certainly enlarged. So there is no question about that. So what are the hematological differentials at this point? I don't know if anyone could unmute and make it more interactive. I'll give it a few seconds if that's conducive with the platform. If not, we all know that it could be a broad range of differentials only if I consider the hematological aspects of it. This could be, for all we know, chronic myeloid leukemia. This could be some myeloproliferative neoplasm. This could also be some acute leukemia. There are some blasts. I don't know what's going on. Or it could be CML presenting in a more advanced phase or something of that sort. But we certainly need more information. There's no two things about it. So this is, for context, what a normal human's bone marrow looks like. This is what your bone marrow would look like if I did a biopsy on you today. So you see that it's very well cellular. And how do you know what the cellularity, what the normal cellularity should be? I know the heme trainees and the heme path guys know a lot more than this, but for the uninitiated, it's 100 minus your age. So if you're a 30-year-old, your bone marrow should be 70% cellular. This seems to be around 60, 70% cellular, or maybe even a bit more. And this could be, you can appreciate some fat spaces, a lot of different population of cells, nothing abnormal, nothing sinister about it, nothing that catches the eye immediately. Even an untrained eye would say, probably this looks okay. But this is when things get interesting. And this is what our bone marrow should ideally not look like. The image on the left, again, for me, it seems to be pretty normal. I don't appreciate significant changes. That's because they are subtle changes. Just some scattered reticulin fibers, no intersections. Again, these stains are H and E, so not the best to appreciate fibrosis if there is minimal fibrosis. But this is what I wanted to actually show, that MF0 is really not too much fibrosis. MF1 you can start seeing, especially if you can see my cursor. This is around the venules, right? So in the perivascular areas, you do see something which is abnormal, something which looks a little more pinkish compared to the rest of the slides, and you'll be able to appreciate more in the next slide. So if you look here, you can see that it starts looking a bit convoluted. It looks like a Van Gogh picture now, gradually starting to take some shape. There is a diffuse increase in the reticulin fibers, some intersection, and still collagen fibrosis somewhere around here. This section a little abnormal than the previous ones we've seen. And an untrained eye can also recognize what looks like MF3 or fibrosis grade 3. And this is to the right side, which is where I'm pointing the cursor. You see it looks homogeneously pink towards this side. And that is because there is a dense increase and a diffuse increase in fibrosis. And if we do some special stains, we could see something more. I'm going to show you that in the next couple of slides. But now back to our patient. We did his bone marrow biopsy because we needed some more information, right? It could be CML, it could be so many other things. And then we saw this. This is the picture from the previous slide, diffuse and dense increase in fibrosis. and this would be graded by any hematopathologist as being MF grade 3. So this is what Mr. X's marrow looks like. And this is what the peripheral blood looks like under the microscope. If you see here, the first slide here shows you some teardrop cells. You can also see something really abnormal, a pretty massive looking cell with a high nucleocytoplasmic ratio, bit of granular cytoplasm in the background of teardrop cells as well. So we can see here that this is not a normal looking peripheral blood smear. And you can see some artifacts, some large irregular platelets, which are also not commonly seen. And when you take this in conjunction, this is what the classical teaching is. This is what a leukoerythroblastic blood picture looks like. You have some immature cells from the granulocytic series. It could be an immature neutrophil, maybe even a blast cell. You see some nucleated red cells, and you can see teardrop cells or dacrocytes, and that is what a leukoerythroblastic blood picture is. So this gentleman has myelofibrosis. Consequently, he's having a leukoerythroblastic blood picture because that is what happens when you have fibrosis in the marrow. And this is now going towards a diagnosis of myelofibrosis, which is not surprising given that we're talking about it today. But we need to know that fibrosis in the bone marrow is not only because of myelofibrosis. It's a broad list of differentials. So you may see a leukoerythroblastic blood picture whenever you have fibrosis, but the fibrosis cannot only mean one thing. It could be that there's something else going on in the marrow and not necessarily myelofibrosis. So there are two types of fibrosis, one of which is reticulin fibrosis. So it is best seen with a reticulin stain. It's a silver stain. And the normal bone marrow can also contain some reticulin. That's just for context. You may see some amount of fibrosis in the normal marrow, sometimes in aging, but you can see reticulin fibrosis in infections like HIV, and when the patient is treated with growth factors. So when L-Trombopag and the others were first launched, and there were concerns about some marrow fibrosis when they were used at the 150 milligram dose in patients with aplastic anemia, this was reticulin fibrosis, not the worst of its kind. What's horrible and what is always pathogenic is collagen fibrosis. So it is best seen again with the trichrome stain. So the initial slides which I was showing you, they were all H&E, so not the best to appreciate fibrosis. If you see collagen fibrosis, you see it best on a trichrome stain, and a normal bone marrow would never have collagen fibrosis. So collagen fibrosis is always pathogenic. And when do you expect to see it? You expect to see it in myelofibrosis, which is understandable, but you can also see it in autoimmune conditions like lupus, Sjogren's, infiltration of the marrow by a metastatic tumor, hyperparathyroidism, osteopetrosis, and with other leukemias like CML and AML. There are so many reports initially that myelofibrosis in patients with CML would lead to a poorer outcome, and imatinib was then shown to reverse the fibrosis successfully. So again, this is not the end of the world. If you see fibrosis even in myelofibrosis, it is reversible, and we're going to talk more about it in the coming slides, okay? But this is what reticulin and collagen fibrosis are. So it's important to differentiate between the two, and your hematopathologist would do it for you. As a clinician, I'm really lucky to work with some expert hematopathologists who really are excellent at their job. But this is the pathophysiology. I said I would try and make it as simple. So this is what a normal signaling is. So JAK-STAT is basically just a signaling pathway. It carries a signal from the cell membrane into the nucleus, and then lets the nucleus handle the signal and do the appropriate thing. So let's just give an example of a growth factor receptor for that matter. The growth factor comes and binds to the growth factor receptor. Now the JAK gets phosphorylated. For anything to work, phosphorylation is one of the important things. So now the JAK is phosphorylated. Eventually, it phosphorylates the STAT, which is its downstream signaling. Eventually, the phosphorylated STAT goes in, it dimerizes, eventually moves into the nucleus, where it can transmit the signal, and that leads to target gene transcription. The target genes could be anything, but I'm talking about myelofibrosis, so I'm just going to talk a bit about some of the cytokines which are upregulated. So it's important to remember a few of them, especially transforming growth factor beta, which is TGF, and VEGF, as well as fibroblast growth factor. These are some of the common ones which are transcribed. But again, the JAK-STAT signaling, which I was showing here, does not only lead to the growth factor, the cytokine transcription. It could lead to downstream signaling via the MAP pathway and lead to cellular proliferation. So the possibilities are endless. This is just a simple, humble messenger which gets upregulated. Now let's see what would happen if this entire process happens without the need of a growth factor. Okay, so if the JAK-STAT is constitutively activated for whatever reason, most likely a mutation, then it doesn't need this growth factor. So even without the stimulus, the JAK will get phosphorylated, the STAT will get phosphorylated, it'll move into the nucleus, transcribe whatever signal it wants to, and eventually lead to proliferation or production of cytokines. So this is what really happens. The cytokines are a function of the hematopoietic stem cell, which has, kind of gone rogue now. So the hematopoietic stem cell is the root cause of all malignancies, right? It all has a stem cell origin. That leads to upregulation of genes which produce cytokines. The cytokines eventually produce a bone marrow environment or a microenvironment that we talk about, which is conducive for its own growth. So it's a symbiotic relationship. One leads to the other, eventually facilitates the growth of the former, and the cycle continues. I already spoke about TGF-beta. OPG is osteoprotogerin, interleukin-8, interleukin-2 receptor, and lipocalin-2. These are some of the cytokines that trainees might want to know. And just remember the names. If nothing, just remember transforming growth factor beta, which is really the predominant driver of things here. And these are the cytokines which lead to an inflammatory milieu, leads to a chronic inflammation in the body. And that's what causes these symptoms of fatigue and low-grade fever. And lipocalin-2 has also been shown to induce double-stranded breaks in the DNA, which eventually leads to progression of disease and genomic instability, right? Okay, so the next part of it, the genetics of it, right? So these three are the driver mutations. Now, what do you mean by a driver mutation? Something which has the ability to let the clone grow and proliferate. So three driver mutations, very well known to people, are JAK2, CALR, and MPL. The JAK2 gene is on chromosome 14, CALR is 9, MPL is 10. CALR has two subtypes of mutations, CALR type 1 and type 2. One's an insertion, the other one's a deletion. We all know this, but it's just for context. And now, as I showed in the previous slide, this is the downstream signaling. And here you can see, I don't know if it's really visible, but the downstream effects could be multiple. I showed in the previous slide as an example that it leads to upregulation of cytokines, but now it's leading to even pro-survival pathways and proliferation and the cytokines, obviously. So JAK-STAT is just a humble messenger is what I'm trying to say. The downstream effects could be multiple. Eventually, what starts with a single driver mutation and is a single abnormal cell, like in any theory of cancer, leads to genomic instability, acquisition of additional mutations, and those are subclonal mutations, mind you. So the driver is always one of the three, and then you acquire more mutations. It could be ASXL1, EZH2, IDH, P53, our good friend, and SRSF2. All of these are subclonal mutations and lead to clonal evolution of the disease. So just again, to summarize my slide, one of these things happens, the driver mutation happens, there is a random hit. Downstream effects are myeloproliferation because of the unregulated growth of these cells, and that happens because of increased pro-survival pathway stimulation. Neoangiogenesis, VEGF induced probably. You also get eventually fibrosis, which is a function of the transforming growth factor beta. So it's not the hematopoietic stem cell or the abnormal cells of myelofibrosis that produce the fibrosis. It's basically the transforming growth factor beta, which is leading to the fibrosis. And eventually that is what causes the symptoms. When you have chronic inflammation, you feel tired, there is fatigue, or also happens with old age, that is. So that's different. But this is chronic inflammation, which is pathogenic. Inefficient hematopoiesis, obviously, because the cells have a survival advantage compared to the normal cells. And that leads to cytopenias, which eventually can cause so many things, infection being the worst of it. And because your marrow is not working, the spleen starts to work and it enlarges. And that is what causes the splenomegaly. Again, big issue in myeloproliferative neoplasms, and that can lead to secondary portal hypertension as well. So that's non-cirrhotic portal hypertension that we see. So this is just a brief outline of the pathophysiology. It could be a little overwhelming, but just remember that the hematopoietic stem cell, the mutated one, because of any of the driver mutations, starts to produce cytokines. Cytokines lead to more production of the hematopoietic stem cell. In the background, there is additional subclone mutations being acquired and proliferation is happening. This is what leads also to the clinical features, which are not too difficult to understand. But this test that we had sent off on this gentleman now, our PCR-ABL has come back negative. So we know we're not dealing with chronic myeloid leukemia. The JAK comes back positive, and we know that it opens up a big umbrella of things. We have polycythemia vera, essential thrombocythemia, primary myelofibrosis, and MPN unclassifiable. These are the things that fall under this category of myeloproliferative neoplasms or chronic myeloproliferative neoplasms. Polycythemia vera and essential thrombocythemia eventually have the potential to transform into myelofibrosis. So it's more like a continuum. You have PV or ET, and eventually you may develop myelofibrosis, which would be secondary, or you could directly start with the myelofibrotic stage. You could start at a pre-fibrotic stage and then move into the fibrotic state. A lot of things happen clinically. The manifestations are different. And what are the clinical features in myelofibrosis then? The marrow here you can see inside is all it's all stony, it's scarred, it's not the best looking marrow. And you have consequent to the cytokines, I already showed you that fatigue and low-grade fever, but you can experience some weight loss, some hepatosplenomegaly, increased risk of infections. These are common. But the dreaded complication is the risk of leukemic transformation. That happens in close to 10 to 15% of cases. And that is something which has an extremely poor prognosis because it's so difficult to bring these patients back into remission. And transplanting patients with a previous history of accelerated or blast phase myelofibrosis is a different ballgame altogether from when you transplant them in the chronic phase, okay? So this is what the risk of progression is. Again, the diagnostic criteria, obviously you need to have bone marrow fibrosis, grade 2 or grade 3. If you don't, then it's pre-fibrotic PMF, but today let's just talk about the fibrotic aspect of it. So you need to have some bone marrow fibrosis. That's one criteria. The second criteria is the presence of one of the driver mutations. Well, now one could argue that, hey, what about triple negative myelofibrosis? That is an entity. It happens when, well, none of these three mutations are identified on testing. That could be because there are some non-testable mutations or non-canonical mutations that exist, but that's the rare cause. More often than not, triple negative myelofibrosis happens because of alternate pro-survival pathways being activated. And that can happen. So you may find another clonal marker on next generation sequencing. So you need to have basically demonstration of clonality is what I'm trying to say. But triple negative myelofibrosis is rare. And predominantly you'll find JAK2 followed by MPL and CALR as the driver mutations. And you have to make sure that it cannot be anything else. Like I said, in this case, we'd had to rule out CML. I also said that MDS can cause a bit of fibrosis, so that can be one of the differentials, but the presentation would be different. PV and ET need to be ruled out before you label something as being primary myelofibrosis. But again, the presentation is so different, it's not that difficult to differentiate clinically. Again, the minor criteria, the patient should have anemia. That could be a consequence of so many things, chronic inflammation, poor marrow production, and so many of the other things. You should have increased white cells. Again, it's a myeloproliferative neoplasm, right? So there should be some proliferation. Leukoerythroblastosis, which is a consequence of the fibrosed marrow. A big spleen, which is what you'd more often than not get unless the presentation is really early on. And an increase in LDH, which is a non-specific marker again, but these are the 5 minor criteria. Don't need all of that. You need all 3 major criteria, though. You need fibrosis, you need demonstration of clonality, and you need to make sure it is nothing else. And you need one of the minor criteria to make a diagnosis. Again, don't do it just on one determination, but more often than not, that's reasonable. I don't think anyone does a repeat bone marrow biopsy just to make sure the fibrosis is really present. If the diagnosis is there, it's going to scream out to you. Well, that was for primary myelofibrosis. Now, if someone has ongoing PV. And we have a lot of patients who have primary myelofibrosis developing on a background of PV. They have PV for years together. The median time would be around 7 to 10 years for transformation. And eventually, the patient could also have ET, by the way. So one of these diagnoses, and then the patient presents with new onset anemia, starts to have weight loss and other constitutional symptoms. Again, you start seeing leukoerythroblastic blood picture, you start to see some teardrop cells, and you see that the spleen has increased in size. Now we know that they're progressing, and this progression is happening in the background, and that is secondary myelofibrosis. And this now is a different entity. You're not dealing with PV or ET. When a patient with PV has reduced phlebotomy requirements, that's when you need to really, start thinking that something's going on. Again, 2 out of these 4 symptoms are required. A previous history of PV or ET plus new onset fibrosis in the bone marrow is a major criteria. Okay, so this is what is the criteria for secondary myelofibrosis. So now we know that our patient has primary myelofibrosis, but again, this is really not enough information. What do we do with it? It's such a broad entity. Patients may be completely asymptomatic at presentation as well, or they may be actively dying. So there is a huge heterogeneity in presentation. So this is certainly not enough information. In today's day and age, I know what more tests everyone likes. You need some genetics, you need some more genetics, so you need cytogenetics, you need molecular analysis. For this gentleman, the cytogenetics, let's say, and this is one of my patients here, so I'm obviously de-identifying him, and 11 metaphases showed deletion 7q, 9 metaphases showed a normal male karyotype, and the molecular analysis identified the driver mutation as JAK2, and he had an additional mutation in the ASXL1 at 43% on NGS. So these are the 2 mutations that he has. His cytogenetics, well, I don't know what risk that would be, but yeah, del7q is almost always high risk, isn't it? We'll talk a bit more about it in the next few slides. So now we know that this is not a homogeneous group by any stretch of the imagination. Our patient seems to have the worst of it. He is old, he is quite sick, and he has fatigue, some circulating blasts. So now let's see how we would risk stratify this patient. So the first contemporary model, I would say, was by Cervantes in Blood 2009. They knew that this heterogeneity exists. And in 2009, they didn't have the luxury of all the molecular tests that we have today. They included just clinical symptoms and some basic blood parameters. They included age, constitutional symptoms, and this is just a dichotomous input that you put in. Age more than 65, yes or no. Presence of constitutional symptoms or not. Hemoglobin less than 10. White cells more than 25 or not. And circulating blasts more than 1% or not. Yes, so our patient, as you see, is right at the cusp of it in the age more than 65, but he has more or less all the other features. So yeah, even if it is just a 1-point variable, he does seem to have a high score. And we can see here, look at the heterogeneity in the survival. These are overall survival numbers in months. So this guy with a low-risk disease is likely to live more than 10 years with the disease and despite the disease, whereas someone with a high-risk disease might not be with us even 2 years from today. So really, this will have therapeutic consequences is what one would assume, right? Things kept evolving. We realized that we need more information, and we started having more tests again, right? So we realized that patients may acquire additional risk factors over the course of the disease, and we need to have a dynamic model. So whenever you do these stats, you need to account for things in a time-dependent covariate. So when they did that, Professor Passamonte's group published this in 2010. The IPSS eventually became the dynamic IPSS. So they didn't take at the point of diagnosis like the IPSS. They accounted for changes in these parameters over time. So again, the crux remains the same. Patients, the curves of overall survival, they separate out very nicely, with some patients living on for years, while others struggle to make a few months. And even those few months are with horrible quality of life. Again, lot of nuance to this, but this is the big picture that not all myelofibrosis is the same. Eventually, there was something which was added to the DIPS. And this was by the Mayo Clinic group by Naseema Gangat and Professor Teferi. In 2010, they published in JCO the DIPS plus score. So what was the plus? What does the plus stand for? Some additional variables that they included. And the most important was, this was the first score to incorporate karyotype. So this was all we had in 2010, right? NGS was not available at the time. No, not too many molecular tests. And if you remember, JAK2 was only identified as recent as 2005 for the first time. So not everyone was getting everything. And this was a retrospective analysis. So it's almost impossible to have information for molecular. But yes, cytogenetics, yes, they were available. They also included the need for transfusion requirements because patients may have low-risk disease, but if they have transfusion requirement and have a horrible quality of life, that would lead to an upgradation in the risk score. So again, the crux remains the same. The outcomes are significantly different between the groups. Decades of survival versus just around 2 years or less than 2 years of survival. So again, calls for different treatment strategies. Then came along the MIPS, and there is a big gap of 7 years between the two scores. Again, this was published in JCO 2017. Now it takes into account mutations. I don't want you to focus too much on the variables included. We have apps and we have websites which really spit out the scores once you enter the details, but just focus on why it was done and the need for these things, because we started getting more information now, right? We knew that absence of CALR type 1 is not good, or rather presence of CALR is associated with delayed progression to leukemia and basically good outcomes. So they had to include that. Also, now we have high-risk mutations which are identified, and these are the subclonal mutations that I spoke about in my pathophysiology slide, right? So ASXL1, EZH2, if you acquire these mutations, it puts you at a high-risk category, right? Because you're more likely to progress. You have subclonal mutations which are leading to further survival advantage. So you have to include these things. Once you know more information, you can generate more scores, and that is what was done. So high-risk mutations, yes or no? Absence of CALR type 1, yes or no? And if you have more than 2 high-risk mutations, that also should be accounted for because you're more likely to progress. Again, you need to have these other parameters from the routine blood work, but I don't want you to focus on those. You can easily do that on a calculator. Again, look at this beautiful separation of curves. And these are overall survival curves, not a made-up endpoint. So this is what is meaningful. You either live or you don't. And this is the true dichotomy of life. You either live 27 years on median or you live 2.3 years. So you really need to do something for this group of patients. Again, MIPS led to MIPS plus. And what did they add to this? They added the karyotype. Again, this is from the Mayo Clinic group. So this paper was also the same JCO paper. They did 2 cohorts. One was the Italian cohort and the other one was the Mayo Clinic cohort. In the Mayo Clinic cohort, they validated it and saw that addition of unfavorable karyotype to the MIPS leads to more, like a better risk stratification. So this is the MIPS plus. If you remember, the DIPS did not include karyotype, the DIPS plus did. MIPS did not include karyotype, but the MIPS plus did. So this is what the scores are like. It can be very overwhelming as trainees to know all the scores, and that's the reason I don't want to overwhelm you with all the variables. Just remember that as time went by, as we got more information, we started making better scores so that we could better risk stratify and identify patients. Then came along version 2. Sorry, this was again by Professor Teffrey, who's done so much work in this space and is an amazing guy. What's the difference now between MIP 70 and MIP 70 version 2? We know that anemia is not the same. It has to be sex and severity adjusted. And they identified one more mutation in that 1 year between 2017 and 18, which they wanted to account for. So they did another multivariable model and assigned scores to it. It led to better risk stratification. All the lines are separating well. So there are multiple models. The goal here is just to make sure that we identify the right patient for the right treatment. That's the only goal. When I see a patient for transplant, I really don't obsess about all the scores. If I have a patient who's completely asymptomatic but has high-risk mutations, it is the toughest transplant conversation I have with these patients. They don't feel a thing, but there's something cooking inside of them. So it's up to you to tell them what's really going on. And that's where these scores are really, really beneficial compared to the previous DIPS and the DIPS plus. So again, we'll speak a little more about it, but not too much more. Simplifying things, they came up with GIPS, which means exclude all the clinical variables, just keep the genetics. Again, Professor Teffrey's group leads to good categorization. And why was this required? Because many times when you get patients from the community, you might not have access to some blood work which was done at presentation or something of the sort, but you'll always have access to the genetic information because that stays with the patient on the record. So if you just have genetics, you can still do GIPS or the genetic inspired score, and that would still risk stratify these patients very nicely. So this is just how the models evolved. As I already mentioned, the IPSS and the DIPSS were the early days, only based on clinical factors. Then we added karyotype to it. Then we added mutations. Then we added mutations and karyotype. And I don't know what we'll add in the future, but anything that really better stratifies my patient, I'm happy to accept it. The goal here is that just remember that some of these names exist and everything started with the IPSS. You keep adding alphabets to it and keep making nice new scores to better risk stratify patients, okay? So this is the calculator I was talking about, and it's an amazing resource. It's a pinned thing on all my computers, the pmfscorecalculator.com. It tells you everything. You just put in the data and it'll tell you all the different scores. Sometimes the scores may not agree, but in this patient, it's a no-brainer. He has high-risk cytogenetics. That is an unfavorable karyotype. He also has ASXL1 mutation, which most of these scores recognize as being adverse and associated with the higher risk of progression. So our patient is high to very high-risk disease. His median survival is going to be less than 2 to 3 years, whatever score you take. And this is a median, okay? So there is a 50% chance it's less than this number and a 50% chance it's more than this number, but it's going to be on an average around 1 to 2 years of survival for this gentleman. Again, 65, completely different ball game in different continents, completely different treatment strategies employed in different continents. We see also in India, patients being much younger at presentation. This does call for a different score, at least accounting for the age of presentation in our country. And I think that is something we should be looking at and collecting data in that space. But as I was talking about, how often do the scores agree? Many a times we see in the outpatient clinic, they really don't agree too much, but that's not what was shown. Only 10% of patients with the low and intermediate DIPS, so that is the old school score, were upgraded to high and very high. So this would be the category with just, an asymptomatic patient, but they have a high risk mutation. So this is the category I was talking about. So they get upgraded. And this is very important to recognize, right? Because this patient would
So
otherwise
sorry
be
to
considered low
interrupt
risk.
you. So requesting you to conclude in the next 5 minutes as
I'm
Dr.
done.
Nico is waiting. Okay, sir.
Yeah, I'm done. Yeah. So you're just basically now risk stratifying them and increasing them to a high risk category. You could also downgrade them to a potential low risk category if they have symptoms, but let's say they have favorable cytogenetics and the likes, they may be downgraded. So the scores many a times do agree. Around 20 to 30% times you do see a discrepancy. Similarly, for the different scores, it's great agreement between the low and high risk groups. So if you're at the extremes of spectrum, the scores would agree, but not otherwise. And again, it's always a balancing act. If you want to balance the curative potential of transplant versus the risk of non-relapse mortality. And eventually, it's most important to know what the patient wants, okay? So management, this is a rough guide of things. Low and very low risk disease depends on the symptom. If you have symptoms, you treat them. If you don't have symptoms, it's okay to just observe, just like we do in so many indolent malignancies. High and very high risk, please transplant them. If they're eligible, just transplant them. And the sooner you transplant them, the better it is. Again, a lot of nuance to this. Nico is going to talk about it, but you need to do that. And intermediate, again, broad category, but the symptoms management depends on the symptoms that you have. Anemia with splenomegaly, anemia without splenomegaly, both of these are commonly seen in patients with low-risk disease. You may have some cytosis or increased blood counts. You need a different treatment. You may have symptoms, but your platelet counts and blood counts don't permit these treatment options. And we'll see in the next 1 or 2 slides what the treatment options are. So these are the drugs which are approved in 2025. Ruxolitinib was the first one which came along in the COMFORT-2 trial. It's a JAK1, JAK2 inhibitor, but has significant issues with causing cytopenia. So it's a little difficult to administer at times, but has the longest data, has been approved for a while now. The next along the line was fedratinib, which was approved in the Jakarta-1 trial. It's only a JAK2 inhibitor. Again, cytopenias are a bit of a concern, but what the trainee needs to know is the black box warning that it carries for Wernicke's encephalopathy. Again, very, very rare side effect, but do check for thymine and give thymine, okay? Pacritinib. Pacritinib for low platelets, P for platelets, P for pacritinib, and PERSIST was the trial which led to approval. And if you see here, we see some new word here, ACVR1. And that's the activin receptor 1. And that is the one which leads to the downstream stimulation of hepcidin and can lead to resolution of anemia. So it can be used in patients who have anemias and with thrombocytopenia as well. That is pacritinib. And momelotinib is the newest drug, which was approved just last year. It's a JAK1, JAK2, and ACVR1 inhibitor. Thrombocytopenia is a bit of a concern with this one, but not too much. What is really bothersome sometimes is sensory neuropathy, which these patients experience. So it's important to discuss this with them before you put them on momelotinib. Again, cytopenias eventually with these two drugs are a bit less of a concern compared to the previous ones. Important aspect in myelofibrosis, as I said, spleen is a big problem. Ways to tackle it. JAK inhibitors usually work well, but they take time. If a patient has to be posted for transplant and they really need rapid control of splenomegaly because that is associated with so many transplant complications like graft failure, you need to do splenic irradiation. Please don't do splenectomies post pre-transplant. My friend here, Nico, showed beautifully that splenic irradiation is feasible as part of peri-transplant conditioning, and splenectomy in his paper was associated with increased risk of relapse. This has been shown in multiple publications. So please don't do splenectomies pre-transplant, but splenic irradiation should be a much preferred option. We delivered 2 gray of irradiation, spleen-directed irradiation on 2 consecutive days just before we start conditioning regimen. And there are some other options like hydroxyurea, splenic artery embolization, and the others. Anemia, as I said, you always ask yourself, is there splenomegaly accompanying it? If not, then you can use some androgens, danazol, prednisone, which is commonly used in combination with thalidomide or the thalic spread option, that is, or you can use len plus spread as well. Erythropoiesis stimulating agents and luspatercept were not found to be effective in this anemia, and momelotinib and pacritinib are the new things which may really help. If you have access to them, the ACVR1 inhibition really works here and can lead to resolution of anemia. Splenomegaly, if it's present, really nothing much is going to come without using JAK inhibitors. And if you're using it, you need to use momelotinib if available, because that would lead to resolution
So sorry
of
to
anemia.
interrupt you again.
I'm done.
Okay,
Yeah,
sure.
thank you. All done, thank you. Just a summary slide if anyone wants to take a note of this.
I think Nico
Sorry for going overboard.
Nihar, Nico is going to leave. Otherwise, he has some.
Yeah, I'm so sorry about that. We can continue in the discussion.
Yes, definitely. We'll see your summary slide also in the discussion, definitely.
No worries.
So,
Thank you.
yeah. So I would invite Nico now with us, from University Medical Center, Hamburg, Germany, and he's the co-chair of EBMT Trainee Committee and some, great, wonderful work he has done with myelofibrosis. Just invite him to share his wisdom with us.
Yes, thank you so much for having me. It's a real pleasure. Can everyone hear me? I hope everything works well. Trying to share my screen. Just to get feedback, can you see the full screen now?
Yes,
Yes, sir.
Perfect. Okay. Yes, hello everyone from the far west, I must say, back to India. I'm very honored and I'm very flattered to be invited to speak about transplant for myelofibrosis. I'm terribly sorry that Nihar's talk had to be interrupted, but he was overtime as usual. I wasn't really expecting anything else, but it's a good thing because he's passionate about medicine.
Public forum, my friend, please.
He's very passionate about hematology in general and also myelofibrosis. So it was a wonderful talk I saw at the end. And thank you for the nice overview and then a nice point towards transplantation in myelofibrosis, which in many times I was faced that it's a quite complicated, difficult scenario to treat. And I completely agree, because as Nihar beautifully showed, that myelofibrosis is a very heterogeneous disease, and transplant is a very broad approach. So in order to transplant a heterogeneous quite well, you have to try to understand the disease and select the right patient quite carefully. And that's what we try to show you in the next few minutes. I will focus my talk on transplantation in general, then how we select patients. We learned a lot. Nihar beautifully put the recent advancements in risk stratification, but I will make the case that it's not really about the categorizations of patients, but rather about the dynamics of how we assess patients over the treatment course. And then the treatment itself, which for transplantation will be quite simple. It's more about the whole approach around transplantation, which makes transplant for myelofibrosis so complicated. And then a lot of work that needs to be done from a clinical perspective, from a physician perspective, into the post-transplant period, which in my perspective is the most important part, next to the patient selection for transplantation, in order to have the best success for our patient. Transplantation, you already heard that. I just want to make the case again. Myelofibrosis is a very heterogeneous disease. We have patients who live for months, but also who live for decades with different treatments, also with transplantation. And allogeneic stem cell transplantation, despite the novel agents, which are not that novel, if we are honest, ruxolitinib exists now for almost 10 years. Almost as long as I started medicine, so it's quite old. You see my hair, I'm getting old. So ruxolitinib is an old therapy. It's not a novel target and not a novel agent. And we still cannot cure this disease with transplantation. And we also cannot really control constitutional symptoms and splenomegaly with JAK inhibitors, because Nihar said you can reduce the spleen quite well with JAK inhibitors. I would argue you cannot, because the response rate is almost 30% only. And a drug that reduces the spleen only in 30% of patients, in my opinion, could be, if you're provoking, not that overwhelming. And allogeneic transplant is still the only curative treatment. And this was beautifully shown, and we will come back to this in the end. That transplantation, from the left side, you see a very fibrotic marrow, can completely reverse the marrow fibrosis until 1 year after transplantation, which proves that transplantation can completely reverse the disease dynamics and the disease sources. And luckily, these are now combined data for MDS and MPN in Germany, but this is seen all over the world, is that transplantations for MPN, especially myelofibrosis, are increasing since even the COVID pandemic, is still further increasing. And also the transformed acute leukemias from MPN are steadily increasing now. Patient selection. You already saw a beautiful image by Nihar, and this is almost identical. And just to show you that we have the scores, you already saw them in the middle here, but there are a lot of other features that cannot really be replicated in reality by just scores. You have to see the patient and face a difficult individual decision. So all this has to be thought about, but also tackled in research. You cannot just do medicine by patient to patient. You have to produce evidence. And that's what I try to show you in the next few slides, that it's complicated, but we are getting better and better. So first, let's start with this most simple scenario, age. A patient is 72 years of age. what should you do about it? Should you do it irrespective of risk? Age is part of risk, but not a dynamic one. So most categories introduce 65 years as a cutoff for a risk point. But what do you do with patients that are older? And another scenario is that the plain disease specific indication for transplantation that really came from the part from the work from Passamonti and from Professor Kröger that showed with a simple retrospective comparison and established the disease indications according to the dynamic IPSS for intermediate 2 and high risk patients. Here you can see that in the black line, bold line. These are patients who got transplanted that clearly benefit from transplant. Patients with low risk clearly do not benefit from transplant due to the high risk of early non-relapse mortality. And patients with intermediate 1 risk, they have a quite heterogeneous outcome. There are a lot of patients who clearly do not benefit from transplantation, but there are some patients, as you can see, who have long-term overall survival, and these patients you want to identify. How do you do that for primary myelofibrosis and secondary myelofibrosis? Because for secondary myelofibrosis, we clearly see the same thing. You can just look at the curves. They are completely resembling the outcomes that we see with patients with primary myelofibrosis for dynamic IPSS. So how do we do that? And the first thing that we should do is try to understand that there are disease-specific risk, but also treatment-specific risk. And this has been shown by our group 6 years ago with a transplant-specific risk system that also incorporates some features from the disease-specific risk systems, including leukocytosis, but also thrombocytopenia, performance status, age now a little bit lower, because patients who are younger or who are older have a different mortality risk than if they wouldn't get any treatment. And then we clearly showed, and I will come back to this again, that patients with MPL driver mutation, they clearly have a significantly improved outcome compared to patients who have JAK2 or triple negative driver mutation genotype. And also patients with CALR mutation have a significantly better outcome with transplantation. And then ASXL1 mutation, but also mismatched unrelated donor are clearly risk factors for transplant-related mortality and overall survival. And the first thing, transplant-related mortality, is the most important thing, I would say, if we face the decision for transplantation, because most patients want to know what is my risk to actually die from the treatment. In balancing my long-term overall survival. And this score could also predict non-relapse mortality quite nicely. So a very practical tool to inform a patient about the decision-making. And also important is that this transplant score can also dissect the former very heterogeneous group for patients with dynamic IPSS intermediate 1. So patients with lower risk disease, I would say, low and intermediate risk, have a high chance of long-term overall survival. So we would say that a patient who has intermediate 1 risk should definitely be referred for transplantation. If they have a low risk and intermediate risk, they should undergo transplantation. And better refer to a transplant clinic. I don't know how it is in India, but in Germany, not every patient who gets to a transplant clinic gets transplanted, because the most important thing that everyone should know is who should we not transplant. And this score clearly helps with the decision which patient we don't want to transplant because of the high risk of early non-relapse mortality. This basically the same thing we've shown last year for the MIP70, for the molecular enhanced IPSS, that patients with lower risk MTSS clearly benefit from transplantation in the MIP70 intermediate, but also high risk group. So in general, I would say, and this is from a work from the ASH Congress last year, that you should consider immediate transplantation for primary myelofibrosis who have a lower risk transplant specific risk. For patients with dynamic IPSS2, high risk, but also MIP70 high risk. And for patients with secondary myelofibrosis, basically the same thing. And everyone, irrespective of the risk, with TP53, either single hit or double hit, should get immediate transplantation, because it's the only thing they benefit really from. Otherwise, they have a high risk of secondary acute leukemia transformation, and then transplant outcome immediately drops quite significantly. And you should delay transplantation by 2 years approximately. You can email me if you want to know details about the decision making we do in reality, and we include it in the model. But roughly about 2 years for MIP70 intermediate, but also lower risk dynamic IPSS, and also importantly that patients with high risk according to the transplant-specific risk system, they are always an individual risk basis. But for that, they should be referred for transplantation. Otherwise, you cannot make this decision. Next thing that I wanted to talk about again now are the patients who are older, and again also who have 17 years of age or more. And in Germany, we clearly see that transplantation for these older patients increase significantly over recent years. In the middle, you can also beautifully see that the comorbidity index reduces over time for these older patients. So patients who are older are healthier and healthier and are less comorbid than previously. So they these risks are always need always a balance. You have your onset higher risk for age, but you have a lower risk of mortality because this patient, although he or she is older, is healthier. And then, not surprisingly, that patients who are older, they usually get reduced intensity conditioning, as you can see in the bottom. And the outcomes are shown here. This is a cohort in Germany from the German registry. And we have quite low risk of relapse. In the middle, we have promising overall survival for this high risk cohort of approximately 55% after 4 years, and a non-relapse mortality that completely resembles the non-relapse mortality for patients who are younger. Next thing I want to talk about is treatment. We heard that almost every patient should get a JAK inhibitor now. This is a standard of care. And I would say no patient should be transplanted without a JAK inhibitor. You should treat a patient upfront with JAK inhibition to see whether you can reduce the constitutional symptoms and splenomegaly. And why this is also helpful, I will show you in a minute for the transplant setting. First, not surprisingly, patients who respond to ruxolitinib, in that case, it was only a study on ruxolitinib, have lower risk of relapse and overall event-free survival, while patients who have no response, or, and this is also important, lost response, they have almost the same outcome than patients who never received ruxolitinib. So this is just to show you that it's very, very important to assess response if you treat a patient with a drug. And if a patient loses response, you should immediately try, if this patient is transplant eligible, to go for transplant as soon as possible. And for that, we can use the ruxolitinib response model for after 6 months, which has like 6 variables: transfusion dependence, splenomegaly, and ruxolitinib dose. And you can clearly see here that this is an overall survival curve for patients who have low, intermediate, or high risk to respond to ruxolitinib, and this is associated with overall survival in the long term. And this is very important because ruxolitinib, if a patient receives ruxolitinib and comes to the transplant clinic, the first question is, okay, what do we do with the ruxolitinib? And in our department, our rationale is, if a patient comes and responds, why should we get off the ruxolitinib if we can use the beneficial effect maybe a few weeks more? Because in general, a patient is in the transplant clinic for about 4 weeks. And this could be used to get a better outcome. So our approach now in this study was to use peri-transplant JAK inhibition, and there was a retrospective cohort with mainly ruxolitinib patient, but also fedratinib. We now have experience with all JAK inhibitors that are approved in Europe. We use reduced dose with ruxolitinib and fedratinib, but also momelotinib during the conditioning phase. So we reduce it to 2 times 5 milligram or 1 times 200 milligrams daily, and then use it until day 21, then taper it off until day 28, and then stop the JAK inhibitor, because, and this is a very important thing to learn, is that JAK inhibition as maintenance, in my opinion, does not make sense at all, because JAK inhibitor do not target the clone. They can relieve a little bit of constitutional symptoms. So if you have a patient that still has constitutional symptoms due to persistent splenomegaly, you could consider it. But in general, this is not standard of care, and there is no evidence that it's really improving anything. And we compared this to patients with patients who, in which ruxolitinib or fedra were stopped, or patients who never experienced JAK inhibition. The first thing that we saw is that with peri-transplant ruxolitinib or fedratinib, we had significantly improved B-cell reconstitution, which is quite important for many reasons, especially when it comes to infectious complications, because one risk with using JAK inhibition was it could increase the risk of infections, but we clearly do not see any association with that. And we could clearly show on the left side that peri-transplant ruxolitinib or fedratinib were associated with excellent engraftment. So all patients engrafted with that regimen. We, in general, already have a high rate of engraftment with 96%, but here we have a rate of 100%. And we saw signs for reduced acute GVHD, but I must say, from a scientific point of view, these are only signals and not really valid. So I would not give ruxolitinib for that reason. I would give ruxolitinib for the reason to improve engraftment, but also to keep patients on the drug to maybe reduce constitutional symptoms. What do we do with patients who have circulating blasts at time of transplantation? Do they have a high risk for leukemic transformation? There is no real association when you consider continuous circulating blasts, but clearly patients with accelerated phase have a high risk for higher relapse and risk of transformed leukemia. And for that, you could use venetoclax and azacitidine as investigational treatment. Why this is important is, first of all, because on the right side, we could show previously that patients who are especially in accelerated phase, have an exponentially higher risk of relapse after transplantation, but this does not translate into reduced overall survival in that regard. So if you sequence and if you follow up patients closely and you see the relapse early without the transformation into leukemia, you can get to simply the same overall survival than patients who have chronic phase myelofibrosis. So accelerated phase myelofibrosis should not defer transplantation, but rather make you the immediate decision for transplantation. The next thing, the big thing, is splenomegaly. Nihar already pointed towards that. Spleen size in many studies has been associated with outcome, especially with delayed relapse, but also delayed engraftment and increased relapse rates. This study showed you that higher palpation or larger spleen size by palpation was associated with overall survival, which in my opinion, maybe as an educational point, doesn't make sense at all, because splenomegaly itself should not increase your non-relapse mortality. You could see it, while this is really an interesting educational point, because this study is a retrospective study from the EBMT, and what has been shown everywhere that splenomegaly is associated with increased risk of relapse couldn't be shown in that study, although everyone knows that, because splenomegaly is associated with higher sequestration, so higher graft failure, delayed engraftment, and ergo increased relapse. So these analyses, in my opinion, are always important to assess for validity. What we see quite clearly when we measure patients with CT scan over a 10-year period for spleen size, that spleen, as you can see at the top in the black dotted line, is clearly associated with higher risk of relapse, but similar non-relapse mortality. But still, relapse is an important thing for patients. So how do we tackle that? And one thing is splenic irradiation. It's quite an easy thing to do if you have a radiologist in your department or close by, and you try to reduce the spleen by a short time before or even during conditioning with focused splenic irradiation. You can see in the middle that what the results are that we did in the global analysis here. And these are points for you to consider doing it, but also collecting data on it to try to understand it more, because it's not a real common thing to do at the moment. And we definitely need to understand it better to make this safer and a real option for patients. But we saw that splenic irradiation really reduces the spleen, even under radiation before start of conditioning or even within days. We saw now patients in the last 3 weeks that reduced their spleen in 3 or 4 days by 5 to 7 centimeters. So this is a really, really promising strategy. And therefore, it's associated with reduced risk of relapse, and shows, and this is quite important, similar overall survival and non-relapse mortality, because for myelofibrosis, the association of relapse and overall survival is a completely different thing than for leukemia or MDS. I will come back to that later. And one thing that is important is that it's quite improving outcomes when it comes to relapse compared to splenectomy, which in my opinion, you should not do. Splenectomy in a very splenomegaly patient is a quite serious operation. It could delay transplantation. We have, over the last 30 decades, not really learned anything more with that technique. Obviously, for patients that have a massive spleen and there are no other options on an individual basis, you can consider it. But if your option is to try to get the best outcome for a transplant-eligible patient, you should not undergo splenectomy for these patients. But splenic irradiation is also associated with obvious adverse events, especially anemia, thrombocytopenia, and leukopenia. Because you cannot completely irradiate the spleen, you always co-irradiate a little bit the liver, and this results into hematotoxicity. But if you use splenic irradiation as part of the conditioning, you don't have any excess comorbidities or serious adverse events with this hematotoxicity, because conditioning already induces also hematotoxicity. So our experience with that technique now, we have more than 20 patients with splenic irradiation now, is completely safe and quite effective. And now another point that I want to make is fibrosis. It's part of the name of the disease, so maybe it's important, but does it really matter? And I would say it doesn't really matter, especially when it comes to treatment decision, because everyone will say now, dude, are you serious? It's part of the name. It should matter, right? But we clearly see that for treatment, for transplantation, for other new treatments, you can see it associations with reduction of fibrosis does not lead into improved outcomes. And we also see that in transplantation. And this is the work now we try to present at EBMT, and which is almost finished, is that we clearly assess patients with their fibrosis from before transplantation and day 30, day 100, day 180. We don't do any fibrosis, any bone marrows now at day 30, and from now on also we don't do any marrows at day 100 if there is no other suspicion of relapse, because we see that it is not really associated with outcome. We can see here that there is no clear association of any kind when you consider fibrosis grade itself and outcome. And we can also see that other markers are much more helpful in trying to assess outcomes in a dynamic fashion for these patients after transplantation. Treatment, quite simply, there's no difference between reduced intensity and higher intensity conditioning. You should do the thing that you're most capable of and familiar with, and try to perfect patient selection and follow up. So this is quite a simple task. There are also signs that treosulfan and a different formulation compared to busulfan as a reduced intensity conditioning has the same effect. So you can use that almost similarly, BuFlu or TreoFlu reduced intensity conditioning. There are also signs that anti-T lymphocyte globulin is associated with better GVHD-free and relapse-free survival, and this comes with a reduced incidence of especially acute GVHD. But still, with the GVHD prophylaxis, use this whatever you're best capable of, because the overall survival in general, if you're not improving selection and post-transplant period, is not that a deep factor for outcome in general. So now the big thing, relapse. How do we tackle that? Relapse, this is our algorithm that we do. We try to reduce the immunosuppression quite carefully and quite early, together with molecular monitoring, but also hematological monitoring. I will come to that at the end. And then according to their response, we either initiate donor lymphocyte infusions and then monitor them quite closely again after 6 weeks, and then give another DLI in dependence of GVHD response or no response, and so forth. And if a patient fails DLI, then we consider a second transplantation. Why DLI? Because we can clearly show that with early DLI, donor lymphocyte infusions, you have excellent response rates, and together with the molecular monitoring, you can target even MRD negativity. So if you have a patient who has only molecular relapse and you give DLI, you have a 15-year overall survival of 80%, which for a relapse patient is excellent when you compare to AML and MDS. So you should do molecular monitoring together with DLI as standard of care for patients with relapse. Patients who are not DLI eligible, you could consider Ropec interferon. We do that now on a case-by-case basis, because we saw that 2 years ago with a patient that failed everything and after second transplant was not eligible anymore for DLI because of GVHD. And this patient got into molecular response by their JAK2 monitoring with negativity and is now still alive. So Ropec interferon could also be an option for DLI in eligible patients. Now comes the big part of monitoring, because everything you do should be, if that is available, should be targeted with monitoring. And that was a work that we could show earlier this year by quantitative PCR for driver mutations, that transplantation is capable of getting rid of the driver mutations quite early, especially with CALR and MPL. So CALR and MPL clear their mutation earlier than JAK2 already by day 30 in most patients, while JAK2 is cleared at later time points, but still quite significantly cleared. You can see at the right the flow diagrams for patients who are negative or positive at day 30, that there is still a significant amount of patients who, even at day 30, who are positive for driver mutations, that become negative at some point in the next few weeks. And this is quite important, and I will show you that in the end, that for myelofibrosis, you don't need to hurry. You have a lot of time for decision-making, because there is a significant amount of patients that needs a little bit of time to get rid of that driver mutation load. And the clearance of driver mutations at day 30 was the most prognostic effect for relapse incidence, disease-free survival, but also, and very importantly, was also associated with overall survival. And this was also associated, and that's why this is quite important, is that it can a little bit make us understand the pathophysiology a little bit more, because we saw that patients who have CALR and MPL and are positive at day 30, they have a completely similar outcome than patients who have JAK2 and are positive at day 30. So clearance defines your outcome irrespective of driver mutation, although you have onset better outcome with CALR or MPL, but if you're positive at day 30, you have almost the same outcome than patients who have JAK2 and are positive. And another point is that molecular monitoring outperforms significantly donor chimerism. So with molecular monitoring, you can identify patients who have mixed chimerism, who have also an excellent outcome. Especially patients who have mixed chimerism and negative for driver mutations. They have the same outcome than patients who have full chimerism and are negative. So molecular monitoring should be, if you have it, should be clearly used for chimerism. And we now consider even not really looking at chimerism anymore because it's not sensitive enough. Even when we do PCR chimerism, which is the most sensitive, I know that 95% of transplant centers use short tandem repeats for chimerism, and this is even less significantly sensitive. And thus, I would say that molecular monitoring with these short tandem repeats, chimerism would even be stronger. So in any case, molecular monitoring, if you have it, should be the standard of care. And this is one of the last slides just to show you that patients who are always negative until day 180. From day 30, they have the excellent outcome with a very, very, very low rate of relapse incidence. But even patients who become negative at some point in the next 6 months, they have also an improved outcome compared to patients who are never negative until 6 months. Worse outcome than patients who are early negative, but still there's no loss of hope for patients who are not negative at day 30. And with that, I conclude. I hope I was on time and didn't overdo it. So one thing is refer timely and early, select appropriately and with nuance, learn to be patient for these patients, and monitor patients closely. And also use donor lymphocyte infusions for relapse. And also integrate novel agents before and during, not after transplantation. And with that, I thank you. I learned that in India, you always say sir. So I thank you all who are out there as sirs. And this is an experience that I had with Nia, who is a good friend of mine, and in Tadoba in India. And I really loved the experience there. And I'm very, very glad again that you invited me. I'm very thankful, and thank you so much.
So thank you so much, Nico. Really, it was really great talk, and so was Nihar's actually. So I have been in touch with you for some of my patients, and in fact, one patient who was a haplograft, you did, help us, plan his strategy and management. So I think I would, ask first our course director to, say a few words and maybe start with his thoughts, and then maybe we can start the discussion. Karan, so it's discussion time, if I'm right.
Yes, so we can go with the
Yeah.
discussion. Yeah.
Start with the Purvi sir's comments. So should we start with the discussion? So if you have your comments, then please go ahead.
I'm in a place where
What?
I have a lot of noise in the background. I'm sorry.
No problem. So I think you did talk about splenic irradiation, and we have explored that strategy in of late. Can you tell what dose of irradiation did you use for splenic irradiating the spleen? What dose
Yes.
did you?
So we do 3 gray as maximum. Depends
It's a single
sometimes.
single fraction, or twice a day.
No, it's fractionated. We do it for five fractionations. But or sometimes 6. It depends a little bit on the schedule. So sometimes you get a slot and then you have to try to include that into the start of conditioning. We sometimes have an overlapping starting splenic irradiation and doing it, and also in the middle start conditioning as well. And then sometimes conditioning and the time slot for splenic irradiation are overlapping, and then you do another day.
Okay.
So for that, you have time.
So
You can
you mean 0.5 twice a day into 3 days? That's what you do?
exactly.
Okay. Fine.
So three gray in total dose, because in the study we did was a vast discrepancy of dosages from 2 gray to 13 gray, and we did not see any association with response or safety. So what we are now incorporating is the lowest dose to have the highest amount of safety for our patients, because still, I must say, it's investigational. So there is no guideline or prospective trial on that. But I think if you do it as part of the conditioning, I think this is the most important part. Then you avoid the prolonged cytopenia and then infection and then comorbidity.
So this was the very question from one of our attendees, Dr. Vishnu, who said that, how would you like to dose with a MAC regimen like Flutrio? Or I do gather that you use a lot of Thiotepa also with your protocols, like a Thiotepa. So just hold on. Hello. Yeah. Okay. So he has fever, I believe, na? So just use paracetamol, hydrocortisone, and Avil. Okay. No, you can give it IV. Okay, and hold the infusion for a while. Okay, and watch the vitals. Okay. Yeah, yeah. That's okay. That's okay. That the level, the number doesn't matter. Send me a message. Send me a message. I'm in a meeting. Okay. Start with the Avil hydrocortisone. Okay, and hold the infusion. Thank you. Thank you. Yeah. Okay.
No,
So-
sorry. It's nice practical atmosphere with managing patients at the
Yeah.
same time.
Yeah.
No, so what we do is reduced intensity conditioning for all patients, except
Okay.
for haploidentical transplants. For haploidentical transplants, we do myeloablative conditioning. For reduced intensity, we do busulfan fludarabine and ATG. For myeloablative conditioning, we do Thiothepa and busulfan. Because for haploidentical transplants, we saw, and Nihar will confirm that, I hope, you see a lot of relapses, which is quite unusual for myelofibrosis. And patients, the next thing to mortality is relapse. You need to talk about patients, and if you know that these patients have higher risk of relapse, we determined that it would be wise to do a myeloablative conditioning to try to reduce the onset risk of relapse. Exactly. But for treosulfan, the results are only similar in the reduced intensity conditioning scenario. If you use treosulfan, for instance, in the myeloablative conditioning, the non-relapse mortality is too high.
Understood. So there is another question, I think, from Dr. Gonzalo Bentolila. So he asks, with the use of PTCI as prophylaxis beyond haplo-HSCT, could MMUD potentially bypass the poor prognosis, and MMUD could be utilized? I believe MMUD is a no for myelofibrosis generally in allos. So now his question is regarding that very fact. Do you see MMUD coming up in myelofibrosis with the new strategies, PTCI and the CAST, and also abatacept coming in with MMUDs and MUDs? Do you see a change happening?
So if a patient has no other option and is transplant eligible, obviously you should do the donor that you have and try to do it in a case-by-case basis. PTSI, in my opinion, in general, also is associated with higher risk of relapse if you only do it with a PTCY regimen. I know, for instance, Nihar's group, they are excellent in combining ATG and PTCY, and they have the similar results that we have, almost.
Okay.
And no, but PTCY, the problem is that we are currently doing a study with in the matched donor scenario where we compare ATG with the only PTCY, and we see quite high risk of relapse, and this is associated with the reduced incidence of chronic GVHD. So PTCY in general, in a lot of studies across the disease spectrum, is associated with very low risk of chronic GVHD. But myelofibrosis, they need chronic GVHD in order to get these low rates of relapse. And it's still a thing that I haven't really understood, to be honest, why this is, why they need it. But it's shown, and this is also clearly seen with the haploidentical approach, that the chronic GVHD rates are quite low, but the relapse risk is quite high. So I'm not really sure if PTCY is really a game changer in that regard.
Could that be because of the intensity of protocols used with PTSI? Generally, they are RIC, and that is true for lymphoid also. For ALL, the problem with PTSI, AML problem with PTSI, all the regimens mostly RIC initially, but now they are moving from NMA RIC to more reduced toxicity regimens. Could that be one cause?
Could be. I would say there is a more really immune
mechanism,
microenvironment, whatever. I don't know. I really don't know. If someone is out there who knows, please tell me. I really don't know.
Okay, so I think Nihar has put his hands up. So Nihar, you have something to say. Please go ahead.
Yeah, so for the splenic irradiation, we've adopted a more simplistic approach to keep things more homogeneous. Be it RIC or MAC, we do it 1 day before starting the conditioning. So that's two grays, 1 gray in 2 fractions on whatever day it is you're starting conditioning, just 1 day before that, to keep things simple and to prevent the hematotoxicity, which Nico was talking about. So this is what we've started following. And I mean, we're going to be publishing this soon. Again, small numbers, around 22 patients who've done this, but really no difference in outcomes that we've seen. And almost stopped doing splenectomies, as Nico rightly pointed out. I mean, that's no longer going to be an approach for these patients unless you individually need them. So just 2 grays 1 day before start of conditioning, be it MAC or RIC. So that, I think, answers the first question, which was in the chat box. And that is how we are using it. Again, for the PT-Psi, we did report at EHA 2024 as well, the ATG PTCY combination in almost 180 patients. And as Nico was saying, yeah, the relapse, yes, but not significantly higher even with the combination. We really don't know if it makes a difference. The MMUD numbers, Gonzalo, were somewhere around 20 or 25 in that, and close to 35 haplos. So we've used this combination across the donor types, and not associated with a significantly higher risk, unless, again, if you look at the haplo subgroup, which we presented at the ASH meeting, that was associated, as Nico was pointing out, with extremely high risks of relapse. Again, it was RIC haplos, and I think Nico is doing the right thing, probably going to MAC for all haplos, but I don't think that's going to be feasible given the age that we see for these patients, right? So lots actually to learn about different donor types and GVHD prophylaxis here. But again, the ATG PTCY combination really is not associated with extremely high risk of relapse, slightly higher than the Professor Kroger group report.
So
I'm sorry, I must go. I'm called to the clinic. Yeah, sorry so much, but thank you so much
really
for having me.
Having you, Dr. Nico. Really, thank you so much for sharing with your
and
wisdom.
please send me any emails if you have any other questions. Yeah. Thank you.
I'll send you a few.
Bye. Thank you so much.
Thanks, man. Bye. Take care.
Thank you. So there are a few more questions regarding dosing of ruxolitinib and peri-transplant management of ruxolitinib. Would you like to comment on that, Nihar?
Yeah. So again, the dose is not going to be the standard which we use for for myelofibrosis in general. It's more in line with the dose we use for GVHD, basically, right? So the 10 BID kind of an approach. And Christine recently showed in the AJH paper, right? Like the peri-transplant approach significantly improves immune reconstitution as well as reduces relapse risk. So I think the 10 milligram dose really sets the bar. It's not associated. The biggest concern people would have would be engraftment issues, but that was not seen in that paper. I don't know how feasible that would be in the real world setting across different countries, but we are not using it for now because of approval issues. But if we would, it would be 10 milligrams twice daily. That is what was shown in their paper. So I would stick to that.
Okay. So, you spoke about the run-through dose, like during the transplant, reducing till engraftment and post-engraftment. Did you talk about that?
I think Nico did because that is what they were doing. And I think they used 10
That is something which is investigational, but it has been seen to reduce hyperinflammation and HLH and all those storms, cytokine storms, which in fact in one of my patients I've used it, and he did have a lot of hyperinflammation, high ferritin, and he did successfully engraft by day 30. It was a haplo. Day 30 was the
Right,
engraft. It had
right.
a lot of hyperinflammation. I had to use steroids starting day 20, and the
Mm.
neutrophils were not coming up. With the steroids, it did come up. It was
Okay.
something, HLH kind of a syndrome there. But
And so
yes,
you mean to say this was a haplo transplant, and did they receive pre-transplant kind of JAK inhibition, or was it
yeah,
like
yes,
was it
yes.
like a JAK
He came to
withdrawal
us.
is what we're talking about?
Came to us. He came to us from another country with on already on
On JAK.
ruxolitinib. So we could not immediately stop it. We had to kind of taper it.
Right, right. I think that should be the approach because what we do is we have a tapering schedule. Dr. Gupta had published this a couple of years ago. We are continuing to follow that for now because that's internal data. And we
Mhm.
stop it like 3 to 4 days before the planned admission date. Now we're trying to do 4 to 5 days because we're incorporating splenic irradiation. So that is how we are tapering and stopping. And we've really not had issues with
Inflammation.
the hyperinflammation. Also could be because we use PTSI for all, right? All donor types, all disease types, PTSI for everyone. I think
Wow.
that may play a role. So between day 0 and day 3 is when we
So that
actually see
brings
the
me another,
CRS. But
another question by Dr. Vishnu. Do you give PDSI and MSD transplants also? So you do, I believe. So Vishnu, I can tell you that PDSI as of now is not the standard of care for MSD, but it is coming in and it is there. In many of the many of the centers have adopted it. I have used it off and on, but not adopted it completely for MSD. But maybe there will come a time when PDSI may become a part, and then maybe a Batacept will come in. A lot of things will change with even with the match sibling transplant, especially the high risk ones, or older age group where you suspect more problems are going to happen. In the very young population, probably I don't see PDC because the risk of GVHD is lower, less maybe less than 12 years. The GVHD risk even they are considering removing MTX out of CSA MTX in below 12 years. So there are things which are age dependent. So I don't know whether PDCI is going to be favored in every kind of transplant in India because it delays engraftment by a few days and causes more of profound neutropenia and some more infections. So I don't see it happening for everybody, and maybe not everybody will adopt it, but many will. And I see Nihar is already using PTSI for MSDs also. That's great.
so
So
I just wanted to weigh in on this as well. So I think
Mhm.
we're looking at, I think we should rather now for the young age thing. Sorry, am I muted?
No, you are not.
Oh, okay, sorry. The app tells me I am. Sorry. So again, for we just published our experience in Blood Advances a couple of weeks ago, couple of months ago actually, about sibling donors only and compared with different protocols over the years. So I think that what we are actually missing is the GRFS. We're not when we look only at GVHD, yes, chronic GVHD, and I would again like to defer with what Nico was saying about the chronic GVHD driving it. I think it's time to accept that we have bisected it, the chronic GVHD and the GVL or GVM, whatever you call it. And I think it's time to actually look at quality of life for the patients as well, because with chronic GVHD, it's significantly bad. And I would rather say for the younger ones, it's even worse because I've seen the CSA MTX cohort, compared them with the ATG CSA MTX, and then with the PTCY CSA MMF, which is now our go-to, and significantly improved GRFS with two approaches. ATG PTCY definitely, but we are worried about viral reactivations, more so in India, I would agree. And the delay in engraftment is not predominantly neutrophil, it's platelet engraftment. So is it really that much of a concern remains to be seen, right? So
The median day of engraftment is about day 15 versus day 12 or 11 with the
right. So
Desai. So there is
again,
definitely delay in neutrophil engraftment, and those 3-4 days actually, become in vital for Indian settings where there's some lingering infections,
agreed.
some ideas, and some patients just can't take that. But with the neutrophil infusions which we use now, we are able to circumvent that. In any case,
Is
so
this
now
all GCSF given? Like you're giving GCSF for engraftment in everyone? Like
GCSF, everybody gets GCSF with PDSI, everybody gets
okay.
all across. In any case, so and the what protocol we use is more of a MAC protocol. It's not a RIC. It's Flumel
Mhm.
TBI. And as Nico was saying, please, to all the students here, I would really reinforce that please don't jump onto papers immediately. Your institutional protocols, perfect them. We have been trying to perfect Flumel TBI for 8 years now. I have not jumped onto Trio. Anything anybody tells, please, perfect your protocols, your ways, and you would definitely see an improvement, and you will match up to many other protocols which you would see in other institutes. So work on your protocols and perfect them, and you will know the toxicities, understand them better. So each institute has its ways. Hopkins has its ways. Toronto has their way, Germany has their way. In every Fred Hutch has their way. People are centers who prefer cord blood, prefer haplo, or prefer muds. You're going to find, no, that's why there is no randomized data in transplant. It's all CIBMT or registry data, which means hardly anything mostly, but they really, push it hard. In any case, so we really need to have randomized data to really concrete, in a concrete way, say anything which we, have to. But we need to perfect our institutional protocols for the students. Nico said very rightly, and he was again and again saying in his talk that please do what you also are, perfecting and you are comfortable with. So what about, Dr. Sharuk has this question. What about graft failure? How often you see? I think Nico, Nihar can take this question. How often you see it? What is the setting you should be wary of? Dr. Sharuk, asking you.
Yeah, excellent question, Dr. Sharuk. I think it completely depends on so many variables, one of which used to be the cell dose, but now I think that's not really a concern. It's now more or less the donor setting when it comes to myelofibrosis particularly. So the average graft failure rate is let's say less than 5% in our center. But if you look at haploidentical settings, it's significantly higher. And I think it's also driven in part by the splenomegaly pre-transplant. And it's very important to optimize, I think, two domains if one can. Pre-transplant JAK inhibition for all does lead to reduction in that risk. Splenic irradiation for anyone with a spleen which is like more than 18 centimeters, 20 centimeters, whatever. Again, as Dr. Mehta was saying, it's the institutional protocol that you follow. Don't jump the gun. That's really important because your comfort really makes a difference. But I would still suggest that, okay, JAK inhibition, splenic irradiation when feasible. If your center has TBI facility, that is one thing that I would probably want to set up for patients with myelofibrosis if they are being transplanted, because that really, really makes a difference. Graft failure is a big problem, as you know, the microenvironment, and it's a scarred bone marrow. You really need to reduce that risk because as Dr. Mehta was saying, like, right, like even too few days of delayed engraftment is a problem, let alone graft failure. That's a short killer, right? You really need to avoid that. And I think the strategy that works best is pre-transplant JAK for all and adoption of splenic irradiation when you have a big spleen size, and avoid a haplodonor when feasible. I know India really does a lot of haplos because, muds are expensive, siblings sometimes not available or older in these patients, but try and get a mud if possible. Haplos have really been shown to be associated with increased graft failure in multiple cohorts. I had a pretty long chat with Professor
Agree.
Kroger about it as
Graft,
well.
graft failure is a thing made of nightmares, and transplanters nightmare. It's going to really take away, your sleep completely, and going to, it's a disaster for any transplanter. So you should
And
avoid it at
one
all
more
costs.
one more point about this, we've got a new protocol for graft failure, like the alemtuzumab protocol, but it doesn't seem to work so well for patients with myelofibrosis. Again, anecdotal
You're using
experience.
alemtuzumab TBI.
Yeah,
We
one day conditioning from the Duke.
we have tried it. We have tried it in one
Yeah,
patient. Did not
yeah.
work. It's okay.
Yeah,
Okay.
we use Fluci Campath TBI, Fluci Cam
Hmm.
TBI. We're not using only alemtuzumab, but I think obviously it's more about the immune modulation at that point rather than myeloablation because that's already there. But it really doesn't work. We have very few patients with myelofibrosis now with graft failure because we've almost tried to optimize things. But when we do this conditioning, the second graft failure conditioning doesn't really work. So just make every attempt to avoid graft failure.
So
And I
just
think, yeah.
look at the ISBMT data of last year. I'm really surprised. You will see
Mm-hmm.
Himalayan gap between the number of muds and haplos. Muds are just down at the rock bottom, single
Right.
digits, double digits, maybe, but
Yeah.
3 digits haplos. So
Yeah,
just
that's
think about where we're going, and if you look at the outcomes,
hmm
I'm not sure where's the ISBMT data for muds versus haplos, but when I talk to people in India are not finding great outcomes with mud, many centers. I don't know why that is there. Maybe, use of ATG is not optimized. Maybe PTSI or abatacept will come in, and we have started adopting abata in some of our patients of late. But please, we all need to sit down and look into the mud data also, dig into it, whether we are achieving the same outcomes with mud as the West has been claiming or has been showing. And
yeah,
then
because
maybe what is better for India. There are ethnic differences with mud. Many, muds
certainly.
are coming from Germany or, or US or NMDP or DKMS. We really need to, and I have seen, I've heard personally, transplanters saying that, okay, this was a foreign mud. So they are also apprehensive of it sometimes in the ethnic differences. How that makes a difference, we need to really analyze, sit down and have some data around that. But I don't believe that we have really hard evidence or hard data to say what we are. So,
Again, because the ethnicity, the diversity that we're seeing here, had DKMS experience, Canadian Center experience, NMDP, and I don't think that that is what is driving it, is what I would think, in my opinion. But I think there is
something
something more.
else.
It's probably like you said, the ATG dosing. There is so many variables in transplant. It's just hard to tease out the differences. It's very right.
Just
But
no,
at least that
so
can be started, right? Like one needs to start.
yeah. So
Absolutely valid point.
last is Dr. Vishnu saying thanks to Dr. Desai and Dr. Nico. Really, thanks from all of us to Dr. Nihar Desai and Dr. Nico for taking up this matter, so well, and answering so many difficult questions so well. And it's a nuanced management. There's so many complexities to the management of myelofibrosis and transplanting it. So I think I would thank everybody and Icon team, Purvish sir, who has been a great support, Karan for really making a huge effort for putting this program together, and all the Kavina team for managing, and Intas for supporting the initiative. Everybody really thankful to all of you and all the attendees, all the students who have taken out time to attend and learn from everybody. The speaker's wisdom here. Thank you, everyone. So I believe I can close the session now. And if Purvi sir, you have something to say, I think yeah.
Thank you very much, guys. Prashant, you've done a fantastic job of moderating, and Nihar and my other colleague. I think I learned a lot. I now realize how out of touch I am with this particular subject and the current management. Nihar, fabulous discussion. And Prashant, with your experience, you really brought out the finer points. Thank you very much.
Thank you so much, sir, and thank you, Nihar, once again. Thank you, everybody. I'll good night, everyone. We'll close the
Thank you
session
for having
again.
us.
We are privileged to have you, Nihar.
It
Thank
was
you.
really great. And thanks to Karan, special shout out to him. He really made sure that everything goes smoothly. He coordinated everything. He's been in touch so many times. Really great, great effort. And thank you for leading everyone so well. Again, huge thanks to all the attendees. Coming to an exam session, I know how difficult it can get. So I tried to keep it a bit basic. Some points may have been a little lost because there is, as Dr. Nico was also saying, that there's so much nuance, but we try to make it better. But you can always feel free to mail me, just call me. We're just one call away. Whatever you need, I can do whatever it is in my domain to help you guys. Always there.
Thank you
Thank
so
you.
much. Thank you all.
Night, everyone.
Wonderful to have you. Thank you. Good night.
Thanks.